Good evening. First off, I would like to thank VOCO for the opportunity to bring you this information this evening. My name is Chris Potts, and I have over 40 years in dentistry. I'm a member of the American Academy of Dental Hygiene, the American Dental Hygienist Association, and a fellow and accredited provider with American Academy of Dental Hygiene. I've achieved additional certifications in caries management, sleep care coordination, and oncology care. My company, Oral Health Promotion Strategies, provides resources, product information, education, coaching for health professionals, consumers, advocacy, and support groups. And I know firsthand the effects of how oncology care can affect the quality of life. I've been a caregiver to loved ones going through treatment and am myself a survivor. I've been a clinical hygienist for well over 30 years. I've seen the impact the side effects of treatment have not only in the mouth but physically and emotionally. My goal is to help you use prehabilitation techniques to keep your patients' mouths healthier during the times when their immune system is compromised. I want to share some things with you that you'll be able to put into use right away that will assist your patients, caregivers, or their family members in preventing what can be excruciating oral effects of cancer treatment. My best friend, Misty, experienced agonizing mucositis during her treatment, and I felt as a hygienist that I should have been able to do more to help. And this is not a course about oral cancer, although that is where our mind usually goes. It's about those many, many patients that we have in our chair each and every day whose lives are affected by cancer in some form. Dentistry is in a unique position to make a difference. The dental provider plays an important role in meeting the unique and often challenging oral health care needs of patients who are impacted by cancer. Skills that we already possess and new ones that we can easily acquire can make the difference in the lives of these patients both before, during, and after cancer treatment. It helps them to manage the common side effects of chemotherapy and radiation therapy and how the knowledge of blood work and critical lab values help to keep patients safe in the dental chair. We're all thrown curveballs in life. I lost my best friend to metastatic breast cancer, my uncle to esophageal cancer, a brother-in-law to oral cancer, my mother to pancreatic cancer, and am myself a breast cancer survivor. And I don't tell you this to elicit sympathy, but I feel that all this led to my calling to bring this information to my colleagues in the hope that it can spare others some of the devastating oral effects of a cancer diagnosis. More and more individuals are receiving cancer care closer to home and therefore are more dependent upon local resources for all of their healthcare needs. And that means that the demand for dental professionals who are trained to meet the oral health care needs of both patients battling cancer and survivors is rising. We're facing what is termed as a silver tsunami of cancer. There are over 15 million individuals with a history of cancer. The majority were diagnosed more than 5 years ago, and that's a good thing. It means that our survival rate is going up, and a good percentage of them are over the age of 65, and that usually means that they're going to have more comorbidities like pulmonary disease, diabetes, congestive heart failure. By 2030, about 70% of all cancer diagnoses will occur in people over the age of 65. Now, cancer doesn't discriminate. It doesn't care if you're rich or if you're poor, if you're male or female, celebrity or average Joe. It doesn't matter if it's breast, prostate, lymphoma, testicular, oral, pancreatic. Cancer does not discriminate. Now, prehabilitation is the comprehensive anticipatory care for oral issues that surround cancer before the debilitating side effects of the disease or treatment develops. It ideally occurs in that period between diagnosis and the beginning of treatment. It's also an opportunity for us to decrease treatment-related morbidities and improve the outcomes. Prehabilitation helps us to establish baseline functional levels, provide targeted interventions, and early palliative care has lowered the rates of hospital readmissions by nearly 50%. Prehabilitation also helps us to decrease overall healthcare costs and avoid visits to the ER. It can also have the potential to increase survival. Now, prehabilitation consists of identification, conditions that could cause issues during that immunosuppressant time, documenting potential sources of gingival trauma, broken teeth, restorations, sharp occlusal edges, areas of food impaction, and it consists of developing a plan for necessary extractions of non-restorable teeth that allows at least 14 days for healing to take place. It also consists of a plan for decreasing the bacterial load and reviewing their oral hygiene habits using an extra soft brush, interdental cleaning, replacing that brush. It also helps us to stress meticulous oral hygiene, the recare frequency, the removal of orthodontic appliances, aligner buttons, attached arch wires, and the recommendation of xylitol. It consists of a full mouth set of radiographs, a baseline clinical exam, and baseline periodontal charting. It also has an aspect of assigning risk based on their current oral hygiene status, their history, high-risk habits like smoking or diabetes, and also I feel the patient's commitment level also lends itself to assigning those risk factors. If we can take impressions for trays, for medicaments, fluoride, remineralization, desensitization, at this point, all you're investing is a little bit of alginate and some stone or a little bit of hard drive space if you're scanning. You can fabricate and charge out for the trays later when the patient actually needs them. But if you wait until they actually need them, good luck trying to get impressions when they are in a full outbreak of mucositis. Prehabilitation also consists of providing education to the patient on what to expect and to what to watch for during their treatment, and scheduling a consultation, developing a relationship with their oncologist. And I know, medical history, what has that got to do with my teeth? But we have to identify risk factors for those patients. 2/3 of health history forms don't differentiate between current or prior use of alcohol, tobacco, or the use of bisphosphonates. Now, some of the obstacles that we have to prehabilitation is the medical community's attitude. In my certification in oncology care from Southern Indiana University, I actually had an oncology RN say that they don't always tell a patient all the side effects of their treatment, because if they knew all the side effects, they wouldn't do the treatment. The medical community also assumes that they can't afford dental treatment in addition to their oncology treatment, especially given the limited patient access and coverage, especially for Medicare and Medicaid patients. There's a lack of bedside manner too. I call them the Sheldon Coopers of the medical world. They're brilliant at what they do, their area of expertise, but they're lacking in incorporating the science into the daily life, healthy lifestyles, and realizing that there's a human being attached to that condition. They tend to skip straight to the how do we get rid of it? We'll schedule surgery for next Wednesday morning. And there's very little dialogue about what you want and how you want to proceed. Then we have additional obstacles of reimbursement, a lack of information, role models, and a resistance to change. The current culture of healthcare is very based on autonomy versus a collaborative type of system. And that's something that I would like to see changed. Another obstacle is the lack of on-site dental professionals in cancer treatment facilities or hospitals. I am so heartened to see the legislation out of Arizona that's paving the way for this type of collaboration. There's a clear disjoint between oral health and general health. Now, some of the patient obstacles that we have to prehabilitation are the patients are unaware of that their treatment outcomes can be complicated by that raging infection that's going on in their mouth. Many are also in survival mode, and the mouth is the least of their concerns. Patients are intimidated by big doctor oncologists, and they're afraid to ask questions. And there is limited patient access and coverage. There's no dental home, and patients have difficulty obtaining timely appointments. We can't tell a patient that calls our office with a cancer diagnosis that our first available appointment is 8 weeks out. They can't wait that long. We need to be scheduling appointments for dental treatment as quickly as possible, optimally 7 days before beginning their oncology treatment, particularly if it involves any procedures that may produce a bacteremia. Now, another obstacle that we have with patients even is, again, the financial aspect. Over 50% of Americans say that when they're faced with a cancer diagnosis, they would be concerned about the financial impact on their families and about paying for treatment. 61% reported that they had resorted to drastic measures to help meet the costs, and that included making early withdrawals from retirement accounts, savings, college funds, taking out a second mortgage, getting another job, working additional hours, or postponing their retirement. And some have even resorted to selling the family heirlooms. Now, newly diagnosed patients are often inundated with recommendations about alternative medicine, cures, and they're from well-meaning friends, family members, and even a few random acquaintances. But 4 in 10 Americans feel that they somewhat or strongly agree that cancer can be cured solely through alternative therapies like oxygen therapy, diet, herbs, and not using standard cancer treatments. And then, of course, we've got the internet. It's replete with a virtual tsunami, again, of information offered from all kinds of sources. Now, experts equipped with evidence-based facts, but they're also people that are just selling products. And outright quackery is there as well. People are looking for the latest iteration of snake oil, and they're going to find it on the internet. People shouldn't expect a website to replace their medical doctor. And over half of responding medical doctors reported that they haven't referred a patient to a dentist in the past year because there is a lack of an adequate referral system. And 65% of the medical doctor offices reported not having any information, such as pamphlets or website contact information, in order to facilitate those referrals to dentists. Now, if we can develop some resources, if we're asked by the patient, we should have information available for dietitians, nutritional therapists, mental health counselors. And we all know patients in our practice or friends that practice a healing therapy like yoga, essential oils, crystals. And regardless of the type of treatment that they're receiving, whether it's surgical, radiation, chemotherapy, all types of treatment can affect the blood glucose levels. It's going to feed the oral bacteria, will build biofilm, cause xerostomia, alter the pH, and all that results to an increase in decay. Now, some of the other acute issues that patients have, of course, we're familiar with the nausea and the vomiting that they experience, and certain oncology drugs are more likely to cause that nausea and vomiting than others. That, in part, is leading to an increase in the use of medicinal marijuana. Marijuana contains two major cannabinoids, CBD and THC. The THC regulates fear-related, anxiety-related behavior. The CBD activates receptors, reducing that fear-related and psychological stress responses. Both cannabinoids can reduce pain. Did you know that we have a vomiting center in our brain? The cannabinoids target that vomiting center and act as an analgesic, an antiemetic, anxiety reducing, depression, post-traumatic stress disorder, and neuropathic pain. Now, in the past decade, the acceptance of medical marijuana has been increasing. Over 75% of the U.S. medical doctors approve of the use of marijuana for medical purposes. The drug's becoming legalized in more and more states within the United States. And we're pretty familiar with the common pain evaluators that are used in the medical community to score pain or discomfort. And when using these assessments, they have shown that the use of the marijuana has been shown to decrease anxiety, depression, and pain and discomfort, and it increases their feelings of general well-being and improved quality of life. And it's predicted that cannabinoids could become part of the standard of care in treating oncology patients with their anxiety and pain. Now, at the dental office, what can we do? How many of you attending are using point-of-care chairside testing? Most of it's not ready really for routine diagnostics yet, but they are rapidly evolving. They're used for screening, and in the future, they're going to become very valuable tools. There are already markers that are in place in the saliva for a variety of cancers, such as breast, lung, gastric, pancreatic, ovarian. And it used to be that such tests required a trip to the doctor or to the hospital. They involved invasive blood or tissue samples, and one had to wait several days to get the result. But nanotechnology has eliminated that limitation, and saliva has distinct advantages over blood. And there are 17 different salivary tests that are currently available. They're already here for caries, salivary flow, pH, periodontal disease, tracking the bacterial count, and biofilm activity. Now, the primary care doctors, most of them would welcome dental office screenings for hypertension, diabetes, HIV, cardiovascular disease, and most say they would be willing to discuss those results with dentists and accept patient referrals from dentists. Now, on the patient end of things, they stated that their opinion of the dentist would improve regarding professionalism, knowledge, competence, compassion, if medical screenings were done at their dental visit. And oftentimes patients visit the dentist more often than they do their general health care provider. And this becomes an opportunity for us to start that process of breaking down the barrier between medical and dental professionals. Now, mucositis. Not every oncology patient gets it. Every experience is very different. It can occur anywhere from 2 to 14 days from their first chemotherapy appointment. It's more common if the mouth and the salivary glands are in the field of treatment. And chlorhexidine is totally ineffective against mucositis. The nystatin rinses, in other words, magic mouthwash, the studies have shown us that there's no difference in severity, onset, or duration compared to sterile saline rinses. There's also no uniform formula for compounding the magic mouthwash, and the suspensions that are usually used are loaded with sugar. Mucositis can occur anywhere along the GI tract, and if it's severe enough, can interrupt their cancer therapy. Candida is just one of opportunistic infections that can occur with a patient with mucositis. It's the most painful side effect, and it greatly affects their quality of life, and it necessitates aggressive treatment. Now, medically related osteonecrosis, it's typically seen with bisphosphonate therapy. That inhibits bone resorption, it decreases osteoclastic activity, and that stuff has a half-life of over 10 years. It occurs more often in males, more often in the mandible. It can occur spontaneously. And if a patient complains of pain, numbness, or heaviness in their jaw, we need to be looking for loosening of the teeth, exposed bone in the mouth, swelling, drainage, and yes, that's an external manifestation of medically related osteonecrosis. Now, nadir, that is the lowest point of cell counts, and that usually occurs anywhere from 10 to 14 days after their infusion. Leukopenia is when the white blood cells drop after an infusion of chemo, and that places the patient at an increased risk of infection, septicemia, and bleeding. The platelet count decreases in thrombocytopenia, that's when the platelet count decreases, and anemia is when the red blood cell count decreases. So some special adjustments to patient appointments that we might want to include would be morning appointments, because a lot of times the patient tires throughout the day. Having a blanket around, because the patients, especially anemic patients, can get very cold. And then detailed written home care instructions, because they have difficulty remembering things. Now, some other special adjustments would be for subgingival scaling and root planing appointments. They can be scheduled, but they should be scheduled according to a patient's thrombocytopenic status. We need the CBC count and an INR test from their oncologist. There are some guidelines that are out there to assimilate between the blood counts and what type of therapy should be proceeded with at that appointment. But again, consulting with the oncologist is imperative. Knowing their cycle of treatment, their regimen, and having that consult, requesting the current blood work, it's so, so important, because if treatment becomes necessary during chemotherapy, it can be scheduled. It just needs to be scheduled outside of their nadir. Now, some other considerations is that it's always been thought that radiotherapy patients may experience an occlusion of their carotid arteries, and that needed to be considered when using anesthetic with epinephrine. But the current studies are showing us that there are no differences that were reported in blood pressure, heart rate, arrhythmias between the patients that did receive epinephrine and those that did not. The ones that did not did report a significant increase in pain. Now, patients also must be monitored closely during their dental treatment for signs of a transischemic attack. Care should be taken when repositioning, especially of the upper body, for cleaning, radiographs, or an exam. That blockage or calcification of the carotid arteries may actually restrict the blood flow to the brain and can result in fainting. Now, chronic fatigue of the neck muscles can also make it very difficult for the patient to keep their head upright or move back. And many that have had head and neck radiation therapy suffer from degeneration of their cervical vertebrae. So while most of the time many patients are just being a PITA, if they have a history of oncology treatment, we might try to be a little more accommodating for them. We can recommend the use of warm, moist heat both before and after their treatment, and the use of anti-inflammatory medications. Do you know any oral myofunctional therapists in your community? Head and neck cancer patients in particular will need to increase their vertical dimension, and the trismus is very unpredictable in its frequency and its duration. Many patients will also experience altered taste and an altered sense of smell, resulting in a loss of interest in their food. Now, the nutritional drinks that are usually recommended, especially if a patient has difficulty swallowing, are usually very, very high in sugar. There are even some medications that can increase their cravings for those sugars and high carb foods. Then there's the ever-present nausea and vomiting that can occur, and that's when we ought to consider and encourage the use of xylitol. Xylitol products can neutralize the pH, they inhibit bacterial growth, they stimulate the salivary flow, they help to satisfy those sweet cravings, and they help keep the blood glucose level consistent. We should not be recommending sugar-based lozenges or candies, and the constant sipping of the water is actually washing away any salivary mucins that they do have in their mouth. So yes, they need to be hydrated, but keep that with meals. They want to avoid sharp, crunchy foods, hot and spicy, highly acidic, alcohol, And then when we start talking about oral hygiene products to recommend, a sensitive deep clean or post-surgical brush, and cleaning interdentally becomes very important. If they've never flossed, now is probably not the time to start, but we need to be working to decrease the bacterial load, and interdental cleaning is very necessary. Now, the trays that we talked about, taking the impressions for early on in their treatment, they can be used to deliver fluoride and remineralization pastes. In order to stop the demineralization of the teeth, the sugars need to be cleared out of the saliva. On average, this takes anywhere from 20 to 45 minutes. It's different for each individual, and there's several things that can affect the amount of time that this takes. If you multiply that by several occurrences over a day, the process begins again every time we take a drink or put something in our mouth. But there are many factors that do contribute to that sugar clearance. One is oral function. How well are they chewing their foods? Are they in pain? Do they have missing teeth? The next thing that could affect it is their salivary secretion. Is it enough? Has their treatment impaired their salivary flow? The buffering capacity of their saliva. Does the person have enough salivary proteins to help keep the dynamic balance of pH in neutral? They may be producing enough saliva, but does it contain enough of the calcium and phosphates? Do you know their resting pH? Have you done the salivary diagnostics? And then one of the other things that can affect the sugar clearance time is the bacterial load, the level of microorganisms, or as I like to call it, the CRAP level in their mouth. Now, we know that it's a very simple process for demineralization. The sugar plus the bacteria make an acid. The acid on a healthy tooth results in demineralization and eventual decay. Now, of concern to us is the neutralization of those acids. Now, we know that the pH of neutral is about 7. Enamel begins to dissolve at a pH of about 5.5. The root surface, the cementum, begins to dissolve at a pH of around 6.2. Now, the bacteria in the plaque metabolize the available sugars, produce the acid, increases the pH, and that allows for the loss of the calcium and the phosphate ions, resulting in the demineralization. Now, the leaching of the materials out of the enamel process takes an average of about 20 minutes. Remineralization needs a neutral environment, and that can occur only once the sugar is cleared. Now, remineralization products help correct that loss, and that results in a stronger enamel. Now, the caries balance, it's fairly easy to adjust the risk factors like the bacteria level, the consumption of the fermentable carbohydrates, and to adjust their salivary flow. It's also fairly easy to adjust the protective factors to stimulate their salivary flow. Add the calcium and the phosphate. Add fluoride to encourage a remineralization and even antibacterial therapy. We can tip that scale in favor of no caries, but pH is going to be the key. That's why we need to understand, we need to ask ourselves, why are we recommending the products? that we're asking them to utilize in planning their home care treatment. Now, some of the first questions that we should be asking ourselves is, what is the desired outcome of those recommendations? Are we recommending a product to provide symptom relief? Are we recommending that product to substitute moisture? Are we recommending that product to promote healing or to prevent decay? Now, do they have salivary flow? Is it reduced or is it totally absent? For a person that has absolutely no salivary flow, we can recommend salivary stimulants all day long. It's not going to change a thing, and then everyone wonders why they aren't showing improvement. We need to know the salivary consistency and the pH. Have we done the salivary diagnostics? Another thing to consider is, does the product contain citric acid? Many products on the market use citric acid for flavoring, but if we've done the salivary diagnostics, determined that their pH is acidic, we would not necessarily want to recommend the products that have citric acid. Does the product contain other sugars that may promote decay? A new product that I saw recently for dry mouth contains sucralose. Another touted that it had organic cane sugar. Now again, many combinations are used for flavoring purposes. But another thing to ask is, how often can they be used? Does it say in the directions no more than 3 times daily, or that it can be used as needed? Is the product better suited for daytime or overnight use? What is their profession? What do they do for a living? When are their symptoms the worst? I know myself, I don't have a large problem with xerostomia during the night, but with my profession and what I do during the day, when I'm talking, when I'm presenting, that is when it becomes the biggest problem for me. Now, are there any contraindications for their ingredients? Is the patient in recovery? Do they have kidney issues? Allergies to any of the ingredients? And palatability directly affects the patient compliance. If they don't like it, they won't use it, and it's not doing anyone any good sitting in the cabinet. Availability and expense also enter into the equation. Now, there are artificial salivas, the salivary substitutes, that are available, and most of them are palliative. They don't do much to stimulate the salivary function. There are a few that have a lot of side effects, and so at that point, the optimal outcome versus those side effects needs to be strongly considered. There are also products that stimulate the salivary flow, and they will bring on the saliva's protective factors. There's also silver diamine fluoride. That can become important to stabilize a patient until their treatment can be completed. There are products that are over the counter or can be dispensed through the dental professional. Some of them are not available to be purchased over the counter, but they are prescription strength to be available from the dental office. And then the trays that we talked about, they are, what do we put in those trays? Fluoride? Yes, definitely. But we can also put in remineralization products. Remineralization can be important for the patients suffering from xerostomia from any cause, not just oncology treatment. And saliva is essential to the remineralization process. So you have products like Remimpro that support remineralization. They strengthen the teeth, smooth the tooth surfaces, neutralizes the acids, desensitizes, and they taste good. It's almost like liquid enamel. Now, there are several products that are out that have remineralization properties, and they're available with and without fluoride. Now, xylitol is one of the things that will help as a protective factor in tipping that caries balance, because xylitol can be a healthy snack. It reduces the plaque on the teeth. It increases the salivary flow, and it also makes more of the calcium and phosphate ions available to be deposited in the teeth. Now, I would recommend 100% xylitol sweetened products. They're available in many forms and provide better treatment outcomes. Now, there are also buffering agents that are out that when we test for the salivary pH, indicate if a buffering product is needed. Again, there are many that are out there that are available. And sometimes the goal is going to be to reduce the bacterial load. There are products out there that not only relieve pain, but contain natural ingredients. They accelerate healing. They fight the bacteria. They don't stain. There's less of a need for opioids and steroids. And as a bonus, they relieve the symptoms of dry mouth. Now, in a recent survey, I asked offices if they dispensed products directly from the office. And most of them said that yes, they do. And there was a small percentage that said, we dispense some products. The most common products that were dispensed are fluoride rinses and pastes, chlorhexidine, xylitol, remineralization products, rinses, and power toothbrushes. And if they don't dispense them from their office, my favorite answer was that we don't want to be used car salesmen. So I feel like there's a huge difference in upselling products to patients and making recommendations for optimal care. And then having those products available to them makes good sense, in my opinion. Now, I've conducted some pretty extensive research on the many dry mouth products that are available today. And this is just a list. It's not intended to recommend or endorse any one product over another. And it's continually updated as products emerge. There are prescription products. There are prescription strengths so that they're only available through the dental office. Some are salivary substitutes. Some provide symptom relief. Some are specifically intended for wound healing. There's some that are no longer even being made that I still see being recommended many times. Now, some are also cost prohibitive to many individuals. Then we have over-the-counter based products that are available at your mass market retailers. They're available online or mail order. They come in sprays, rinses, mucoadhesive discs, gels, pastes, lozenges, and or gum. Now, some are more palatable than others. Some contain inappropriate ingredients. And what works great for one may not work for another. Again, what is your goal for that patient? What will they use? There is not a one-size-fits-all. And especially with oncology patients, their needs can change along with the progression of the treatment. So one of the main takeaways from all of this is to know what we are recommending and why. And also to remember that proper treatment can involve multiple therapies. We need to be a detective. We need to ask the right questions for those individuals. Utilize the prehabilitation, the anticipatory care, and have a variety of products that we recommend. Because remember, one size does not fit all. And our patients will thank us for those recommendations. Now, how can we make a difference in the lives of these patients? We can start with educating other providers and endorsing the referrals to those with the expertise. We can educate other caregivers. We can offer ourselves as a resource to the patient as they progress through their treatment. And that results in having a positive impact on that individual's quality of life. And I think that this is time here to go to some of the question and answers that some of the attendees may have had. We'll do our best to answer those. One question is it 7 days or 14 days having dental treatment done before they start their cancer treatment? Ideally, anywhere the 7 to 14 days is if they need an extraction for an emergent tooth, a non-restorable tooth. Ideally, having the exam, taking impressions for the trays, doing any cleaning or periodontal work that they need, going over their oral hygiene, should begin, their treatment should be completed, their mouth should be on a road to health at least 7 days before they start their treatment. Now, another question is that I have seen more patients who don't eat breakfast at home but will wait until they're at work. If the sugar clearance takes 20 to 45 minutes, should they still brush at home before they leave for work or after eating? I would recommend, in my years of experience in treating patients, that yes, I would brush before I left for work because you're going to physically remove the plaque and the bacterial load. But the sugar clearance aspect, you could utilize the xylitol to help lower the pH. They could chew some gum or rinse to lower that pH and speed up. The xylitol will take at least 15 minutes off of that sugar clearance time because it can reduce the pH in about 5 minutes. Now, can the silver diamide fluoride be removed? I was under the impression it permanently stains the tooth. Yes, it does permanently stain the tooth, but if that patient is having decay issues but cannot undergo treatment right now, then it at least stops the decay and keeps them stabilized. That area can be removed and restored at a later date. And I think to get patients out of pain, they aren't that as concerned with the staining on that. Now, the product chart, yes, I would offer that to the attendees. Again, you can email me. This is my email up here. You can also go to my website, chrispottsrdh.com. It is listed under the, the product, the resources and products on my website. Let's see, we have a lot of questions in here. The KFI is new, using KFI in place of SDF. It is new, and I don't have as much experience with that, but from what I understand, it could be a very viable product to be used on these patients. When a patient has oral mucositis, what do you recommend for oral care? Many times these patients can't even brush. There are some of the products that are available that can actually prevent the mucositis from occurring. That's why the prehabilitation is so important, because so many times we can prevent it from getting so bad. Now, they have the super sensitive toothbrushes that are out there. They're surgical grade. They are extremely soft, and so the patient can actually brush with a lot less discomfort with that. But there are many products that are out there on the listing. If you go to the website, it tells you a lot of the indications of the different products that are out there. Now, the information that I provided today, it may not be sufficient to fully implement a protocol, but I also offer live courses that can be tailored to fit the needs of your audience. And I offer coaching for individuals or practices. I have other topics that will soon be available by way of webinar. And for that list, if you would go to my website under the resources and products. You can also, I invite you to check out my Facebook page, Oral Health Promotion Strategies, and consider me as your resource for xerostomia related questions in oral care. One more question is, have I heard of fluoride trays being used during a radiation session? I don't recall hearing that it's used during the radiation session. A lot of times, those sessions don't last that long. They're very short, each individual session. The total treatment lasts a little bit, can last several weeks. But I wouldn't think that the fluoride trays need to be in place during the actual radiation session, would be my take on that. I certainly don't know that there's any reason why they can't be, but I would consult with my radiation oncologist for information on that. So, any other questions that we have? What medications are we recommending for mucositis? Antibiotics are not going to help much with the mucositis, but again, the listing on the web page, or if you email me, I can email you a copy of that you could utilize in your office. That indicates the different products that can be used for mucositis. A couple right off the hand are the Periosciences, the Vega Oral Care. Closest has been recommended for preventing mucositis. Forward Science, the Saliva Max, also has been reported to reduce the incidence of mucositis. So there's several different ones that are out there, but there's a series of questions that we need to be asking our patients about what is the ultimate goal that we're trying to achieve. And keep in mind that one size doesn't fit all. Because of the palatability of some of the products, this product is going to work very, very well for one patient, but it's not going to have any effect at all for this patient over here. This product may also work really well for several days or several weeks, but as a patient progresses through their treatment, their needs may change. and that product may not work again. That's why it's so important to have a variety of products in our arsenal that we can recommend to the patients and that they can find. It used to be that there was only, 2 or 3 products that were recommended over and over again for the patients. And if those didn't work, then especially the oncologist did not know what else to recommend. And that's part of my mission, is to get the message out to the caregivers, have that discussion, develop that relationship with the oncologist so that they can benefit from our expertise of what goes on in the mouth and the things for the oral care during that time of oncology that they may not be aware of. And so educating those that are in that position to make the difference. Now, if a patient is undergoing chemotherapy, isn't dental care especially contraindicated due to the low immune system? Not necessarily. Again, prehabilitation, getting that patient in a healthier state before they begin their therapy. It's not always possible, but that's our goal. That's what we want to strive for. But it's not contraindicated. It depends on their nadir, their blood counts, the having, again, that discussion, that relationship, that rapport with the oncology team. And a lot of times they say, oh, well, you're just cleaning their teeth. No invasive procedures. And they don't understand that even just a prophylaxis can be invasive, and that periodontally involved patients, the scaling and root planing appointments, is invasive. So again, depending on their blood counts, you may need to delay it. You may need to postpone it. We may need to offset it with some other products, but it does not mean that it's contraindicated. They can have treatment. It just might have to be delayed or rescheduled on that. So I think we're just about out of time. If there are not any more questions on that, I can turn it back over to Viva Learning. And I thank you for your time and your attention this evening. And I do encourage you to consider me as a resource. Go to my website, email me. I've got my number out here. Call me. I'd be more than happy to discuss this and these aspects of things with you at any other time. So I will say good night. Thank you again for attending. It's been a pleasure, and I hope that everyone gained something from this evening. Thank you.